Good afternoon, everyone. This is Shireen Risk, CFAL York's Operations Manager. And on behalf of the organizing committee, I would like to welcome you all and thank you for your participation to the Agent-Based Modeling for Public Health bi-weekly speaker series. Before we get started to this session, I would like to play just a very short video in memory of our colleague Tom Hurd, whom we have sadly lost due to sudden illness. Tom was the team lead who hosted the first two sessions of this webinar series. So I'm gonna play the short video to remember him at the beginning of this session, and then Professor Wu would take over the floor.
Thank you for the picture, and I didn't hear the voice, and I hope it's just only the issue with my computer. Can you hear me, Sherry?
I didn't hear it either.
I can hear you. Oh,
okay.
Shall I try replaying and removing my speaker?
Yeah, we are going to fix this and hopefully play it again at the end of the session. Thank you.
That's good. So good day, everyone. So the Mathematical Public Health, along with the organizer, CIFA, and the Fields Institute, is very sad to know a major contributor to this speak series and major contributor, a dear colleague of our Mathematical Public Health Network, Professor Tom Hurd, passed away on April 28th at the age of 65. So we are going to spend a few minutes to dedicate to his memory. I would like to request a few moments of silence in his memory. Thank you. So Tom Hurd, professor from McMaster, and he is the founding director of the Financial Systemic Risk Lab. It's a major lab of the McMaster University, but it's also in close collaboration with the Fields Institute. And in 2021, Tom joined the INSEC PHAC funded Mathematics for Public Health Network, and he's been really a major contributor to a variety of activities around the ABM, the agent-based dissemination, and bringing his outstanding expertise in the risk management and agent-based dissemination to a truly integrative approach that of the network. And Tom is a Fields voice in the network to ensure that we do things appropriately and relevant to public health, but with the mathematical rigor. And Tom is still a colleague, and at the age of 65, he has decided, once he decided to join the network, he really fully committed. He is one of the few colleagues that have seen how much dedication to the teamwork and to the well-being of the network and this national network. Tom was diagnosed with brain tumor on March 20th, and he folded the deadly tumor very bravely and was very well taken care by his colleagues, his friends, and family members. And fortunately, he passed away on April 28th at the age of 65. And this is news I heard from his colleague that with a lightning time and a larger team of doctor community for friends, doctors, and nurses mobilize the substantial expertise of the university to donate Tom's beautiful mathematical brain to the Schindler Science Lab at McMaster University. So his family, his colleagues, and friends are extremely honored and to see Tom's inquiring mind and generosity of spirit to help advance the study and research of this awful disease. Many of you have very fond memory of Tom for his unique combination of the mathematics, his demand for the mathematical rigor, but really the humor, as I mentioned, his really full dedication to the teamwork. Tom is supposed to, has promised to offer a graduate course in the fall term, and his colleague have decided to take it over and to offer that course in full honor for memory of Tom's. And I think the Tom is co-leading this ABM project team along with Ali and Nathan and many other colleagues, and he's also participating fully in the network. So it's a huge loss to the network, to the mathematical community, but it's also, I think, in Tom's spirit, the best way to honor Tom is really to continue our effort to really push on the integration of several computational platforms that can be used as a powerful supporting tool towards the public health decision makers. I'm wondering if any panel members want to say anything in memory of Tom. So again, I want to thank Sifa and for this special opportunity for us to have the platform to honor Tom, and I would like to thank Ellen Rafferty to allow us to using these few minutes to dedicate to Tom. But as I say, the best way to continue the legacy of Tom is really to continue offer to speak serious, and that Tom is one of the chief organizers.
Thanks
So
a
with
lot,
that,
Professor Wu, and thanks. After your permission and Ellen's permission, if you don't mind, I can try sharing the video to see if the audio would work in memory of Tom.
oh, yes, please.
let me know if the audio is working.
It's working with still. I still don't hear the voice.
No, me either.
I guess it's on, but okay, so I guess we can try at the end of the session if it's not working now. So
We'll try it
don't
again,
lose
yes,
time.
but
Yeah.
it would be very nice to hear Tom's, this is really magic, magnetic voice that would be really appreciate. So with that, let's now move on to the scientific part, to continue the series that Tom, as I said, is one of the main, the driving force. So I'm very glad to have Dr. Ellen Rafferty with us. So I mentioned the NSIC PHAC funded network, Mathematics for Public Health, and Ellen is actually is a co-investigator and project manager of another network, One Society network, and is the co-investigator and the project manager. She's working to incorporate into sectoral perspective into pandemic response. Dr. Ellen Rafferty is a senior health economic at the Institute of Health Economics and an assistant professor in the Department of Medicine, University of Alberta. And Ellen has a PhD in epidemiology and health economics and a master of public health from University of Saskatchewan. Dr. Rafferty's research focus on the epidemiological and economical impact of public health policies and infectious diseases, and I'm particularly interested in Professor Rafferty's work on estimating cost effectiveness of immunization programs. So Ellen, thank you again for joining us.
Thank you so much. I will share my screen. Let me know if you can see it okay.
Yes.
Okay, perfect. Okay, yes, thank you for that introduction and the in memoriam of Tom. He sounds like a great person. I didn't have the benefit to meet him other than through this forum, and even in this forum he was engaging, and it was a fantastic opportunity to meet him. So today I'm going to be talking about the value of agent-based.
Ellen, we didn't see your screen. I don't know if I have shared screen already.
Oh, sorry, I thought. Here we go.
It is.
Perfect. So now you can see it?
Yes.
Okay, fantastic. So first of all, I want to just acknowledge all my co-authors and my supervisors who worked with me on this project. We had a great interdisciplinary team of epidemiologists and computer scientists and infectious disease modelers, one of whom is here today, Wade McDonald, who is very integral in this work, but also Nathaniel Osgood and Alexander Doroshenko, Mara Farag, Cheryl Waldner, Heather Gagnon, and Shannon McDonald. All were key in getting this work done and completed in the way you see it today, as well as the continued support of the Institute of Health Economics and the University of Alberta. So just a brief outline of what I'll be talking about today. So first, I'm just going to touch on where we are at, or I guess where we were at with agent-based modeling in cost effectiveness of immunization studies, and where we could maybe go further. And then I'll talk about the specific agent-based model that we developed focused on chickenpox and shingles, and talk about some of the results that we produced using that model. So looking at the impact of the chickenpox vaccine on shingles, evaluating different chickenpox schedules, as well as the cost effectiveness study. And then maybe if I have time, but I'll definitely leave time for questions at the end, I'll talk about some of the strengths and limits to ABM for immunization that we discovered on this pathway. So first of all, I think I wanted to touch on the scoping review that we completed, and the scoping review the goal was really to describe general trends and gaps in the cost effectiveness of vaccines in the Canadian literature. And what we found was that sorry. Oh, and just to clarify this, the scoping review was completed in 2017, and I think this area of research has improved and increased greatly since that time. So just to note that. So what we found was that there were quite a few limitations in the modeling that was being used in this arena. Often transmission wasn't being taken into account, very limited use of individual or agent-based models. And I think at the time we found that there had been 5 studies that used agent-based models to evaluate the economics of vaccination programs. And they had all been published in the last 5 years, but that it was increasing and continuing to increase and becoming more popular. And I think that probably just continued on, especially with COVID-19. I've seen quite a few models that have taken into account both the epi and economics. So that is exciting. So just to give a brief background on chickenpox itself for those who may be new to the area. So chickenpox is a disease caused by the varicella-zoster virus, and it's actually the primary infection caused by the varicella-zoster virus. And it is a very common disease prior to vaccination. So about 90% of people had chickenpox by the age of 12. And that was generally a good thing, because if you got it when you were older, it was often more severe. However, it was, typically quite self-limiting and, well, very annoying. I can attest to that as someone who had chickenpox. It didn't commonly cause long-term issues, although they were possible. So there were some complications associated with it, bacterial infection, encephalitis being 2 of them. So once the primary infection cleared for varicella-zoster virus, the virus remains in your body, and a secondary infection can occur. And this secondary infection is shingles. And so that happens when varicella-zoster virus is reactivated in your body. And there are multiple risk factors that have been identified for shingles, including cell-mediated immunity impairity, age, mental health, gender being a few of them. And the complications associated with shingles, and again, I assume anybody who's had shingles can attest to this, can be a bit more severe. So there's post-herpetic neuralgia, which is basically long-term nerve pain, eye infections, nerve palsies, as just a couple of them. And the lifetime risk, so not everybody who's had varicella does get shingles. So the lifetime risk is somewhere in the range of 15 to 29%. But the question remains, so why do some people get shingles and some people not, even though everybody has had chickenpox? And one of the theories that was posited was this waning and boosting of immunity. And this has some evidence in the literature that as your immunity to the varicella virus wanes over time, and after it reaches a certain level, that is when shingles can reactivate in your body. And there is some evidence in the literature as well that if you come into contact with a chickenpox case or a shingles case, this can boost your immunity to the varicella-zoster virus and therefore reduce your likelihood of getting shingles. And this is called the theory of exogenous boosting. And the theory of exogenous boosting has sparked a debate in the literature, though it's starting to be settled, about whether the chickenpox vaccine will limit the boosting of immunity to shingles, because you're not coming into contact with the varicella virus as often, it's not spreading in the community because we have an effective vaccine, and therefore increase the incidence of disease. So you will see a greater increase of shingles. However, the empirical data to date is largely inconclusive. So, there's some studies that show that is happening, some studies that show it isn't, and I'll touch on that in a second. So Canada did implement a universal varicella vaccine, and they did this kind of in the early 2000s. It did differ by province. So if you see here, I think I can have a pen. If you see here, varicella vaccine was approved in 1998. And then it was privately available for a few years before being publicly implemented in a lot of provinces in the early 2000s. So for example, Alberta implemented in 2002. And after that, you do see this great decrease in number of cases. So you still see some chickenpox in the community, but at a much more lower rate than prior to vaccination. So the vaccine is working very well. It's doing its job. But what does that mean for shingles? So this is an older study, but I think illustrates the issue well. So this is shingles rate over time. And you see that, yes, it did increase following chickenpox vaccination, but it was already increasing prior to chickenpox vaccination. So how can we, really link any increases to chickenpox vaccination and not to whatever was happening before? And similarly, when you look at age group, yeah, this like longer dotted line here is post vaccination, and you see the rates are slightly higher in the older age groups. But how we tie this to the vaccination is still a question. And we do see in the younger age groups that it's actually lower. And we did a study that also showed this, that shingles rates, so these are pediatric shingles rates following vaccination. So vaccine was implemented, like I said, around 2002. And then following that, you do see an increase in each of the age groups as they kind of age up so the dotted line is when the vaccinated cohort would have been in that age group. So chickenpox vaccine is not only protecting against chickenpox, it's also protecting against shingles, at least in younger age groups, because the virus isn't able to remain in your body in the same way post-vaccination like it did post-infection. So this is a good sign, but doesn't answer the question about whether we'll see an increase in shingles post-vaccination. So what were our project goals? So we wanted to determine how chickenpox vaccine would impact shingles incidence rates into the future. We also wanted to evaluate various immunization schedules for the chickenpox vaccine. So I'll touch on why that was a concern. And then we wanted to conduct a cost effectiveness study of the chickenpox vaccine, considering goals A and B. So the model itself. So I'll just start with a brief description of the model we built and why we built it as we did. So the model was built in AnyLogic, and this is a slightly simplified version of the disease state chart, but it captures really everything that we need. So individuals are born into the population, and they start with some protection via maternal antibodies. Over time, they become susceptible to disease. And from here, depending on whether we have vaccination enabled or not, they can either, if they receive a message, they have a certain likelihood of being infected with chickenpox. And then if vaccination is enabled, they have also a likelihood of being vaccinated with 1 dose or 2 doses of the vaccine. However, there's also a chance of breakthrough chickenpox. And so once you're infected, you're infectious for a little bit, but then you become non-infectious. We also obviously represented vaccination. And so this is how messages are sent to the eligible population. So when they're due for the chickenpox first dose, and then when they're due for their chickenpox second dose, this is based on the current schedule. So here, I believe due chickenpox first dose was at 12 months and chickenpox second dose was at 4 to 6 years, because that's the schedule that had been used in Alberta. But then a person's likelihood of being vaccinated is actually dependent on a variable we use around vaccine attitudes. It's not captured here, but one's vaccine attitudes was linked to your parents' preferences. And it was through the attitudes that vaccine coverage was derived. Okay, so now going to kind of the slightly more complicated portion of the, sorry, just 1 second, of the disease state chart. So this is how we captured waning of immunity. So when people were recovered from chickenpox, they go into this state, and from this state, they have a waning of immunity timer that kind of tracks how their immunity to the varicella zoster virus wanes over time. So it's kind of ticking down as the years go on till eventually they become susceptible to shingles. However, they can be boosted in their waning time by contact with somebody with chickenpox, or with a breakthrough illness, or with shingles, but mainly through those with chickenpox. This can boost up their waning timer. And the waning timer is a continuous variable that decreases. And so once they've reached this susceptible to shingles state, they can then become infected with shingles. So they have a chance of becoming infected with shingles across time. From becoming infected with shingles, they can develop long-term consequences, the big one being post-herpetic neuralgia, which we have captured here. They become non-infectious and then recovered, and again have a certain risk of getting reinfected, although a small risk, because the risk generally is quite small for reinfection. So that's the disease state chart that we were working with. We also captured chickenpox vaccination. So it depended on which model we were using, but we often did not incorporate it because at the time, and still to date for Alberta, shingles vaccination was not publicly available and not funded. So everybody who wanted to receive it had to pay out of pocket, and we found the coverage rate for shingles vaccination at the time was quite low. It might have increased now with the new vaccine. It's a better vaccine, and I think coverage rates have slightly increased, but at the time it was very low. But we do have that capability in the model. So just to give a bit more detail about the contact network that we used. So we used a distance-based network. So people contacted people who were close to them based on their connection area and then on a contact rate. It was a stylized network. It was a stylized geographic area where we had about 20% of people who were in the low density periphery and then 80% in a higher density central region. And we also had kind of a preferential contact group for the younger age groups that had a higher rates of contact with others in the same age, because this is key to the transmission of chickenpox, is that people in younger age groups often connect quite dramatically with other people in that same age group. In terms of transmission, we represented disease spread and boosting through this contact network. And if you were infected, you sent messages to those in your network. And then they had a probability of being infected or boosted, for that matter, per contact message. And this probability was based on whether the message was coming from somebody with like kind of original chickenpox, and then was lower for those who had a breakthrough case, because it's generally less severe than a typical case of chickenpox, as well as a shingles case, because you're less likely to transmit with shingles than chickenpox. Chickenpox is quite transmissible, whereas shingles is less so. So then we calibrated the model to epidemiology in, I think this was in Ontario, pre-vaccination. So the red line here is the epi from health administrative data, and the blue line that's kind of hard to see is the model data. And we found that our model had higher rates than the health admin data, which is not surprising because chickenpox is very much represented in health admin data. Often people don't go see their physicians if their child has chickenpox. At the time, it was a very common childhood disease. People were kind of expecting it to happen at some point. So unless there was a specific reason, they often didn't go see their doctor or didn't go have another connection with the health system. So that is why we did increase what was shown in the literature. And once we did that by 2.5 times, we saw that they matched up very well from our model and the literature. The kind of more complicated, and I'm sorry for the small letters here, but the more complicated calibration that we had to do with this waning and boosting of immunity. So as you can imagine, these two variables are linked, right? So if you're trying to match to empirical data, and you use both boosting of immunity and waning of immunity, if you increase one, and if you change both of them at the same time, you might be able to get to that empirical data through a variety of different parameter sets for these two variables. So for example, this one on the left has a duration of boosting of 2 years. So the lowest duration of boosting we found that fit our criteria for inclusion, and a waning immunity coefficient, which represents waning of immunity, of 0.5. Whereas we got a similar result, maybe slightly better, when we used a duration of boosting of 5 years and a higher waning of immunity, right? So if you increase duration of boosting and increase waning of immunity, then you might end up in the same place. And we found this, we were able to kind of represent empirical data using 6 different parameter sets. So ranging from 2 years at the lower end of duration of boosting. So that means the individual, when they came into contact with a chickenpox case in the model, were boosted for 2 years. They got 2 years of additional protection. And then a lower waning of immunity. So their immunity wanes slower. And up to 7 years with a waning of immunity coefficient of 0.74. So their waning of immunity occurred more quickly. So you can see how this got a bit complicated, but it ended up in some interesting results. And our best fit model was actually this 5-year one in the middle here that fit the empirical data the best. Okay. So that gives us a background on the actual model, but now I'm going to jump into some of the results we did and some of the experiments we did using the model. So first, we wanted to, as I mentioned, evaluate the impact of boosting and waning of varicella immunity. So we compared those 6 boosting scenarios that I just outlined and used paired runs for each of them with and without chickenpox vaccination. So we made sure that the runs were completely the same. The only difference was that chickenpox vaccination. We had a small initiation of the model of 25 years, and then we ran the model for 75 years to really get at the full impact of the vaccination over time on a population of about 500,000 agents. And here are the results. So as you can see, the results and the impact on shingles really depends on what duration of boosting and waning of immunity you're using. Now I always see DOB and I think of date of birth, but this is duration of boosting. So as you see here, the light blue is the model without vaccination. And then the red is the model when we add vaccination at this duration of boosting and this waning of immunity. And you can see when we're talking about a 2-year duration of boosting, that the impact on shingles is actually quite small. So yeah, you might see a very small, maybe difficult to detect increase in shingles, but there is still quite a bit of overlap. And then, and this is consistent between all model runs, we start to see a big reduction. And again, this is what that phenomenon I spoke about earlier that we saw in the epi data, where people with chickenpox vaccine are kind of aging up, and they're less and less likely to get shingles than people who had original infection. I'm assuming a lot of us, though maybe there are people who are younger than me who were lucky enough to get vaccinated. And so you can see this phenomenon. The other thing you see is that as the duration of boosting increases, so as the assumption about how much extra time you get before your immunity wanes to a point where you get shingles, so as that increases, you get more and more shingles increase in the population following vaccination. So at 7 years, you see it's a huge increase. It's about 75% at the highest level. You may expect to see, 75% more cases. And I mean, currently we have not been seeing this in the literature. We are farther more down here, but it's an interesting thing to think about and consider. Because everybody thought we were going to be here. That was the big concern, and a lot of the reason that people didn't pursue chickenpox vaccinations at the beginning was because of that concern. We also can present results by time and age. So these are the different time horizons. We'll focus on the green one. So that is the full time horizon. And it's similar, you can see that in those younger age groups, we're seeing a reduction of shingles cases post-vaccination, but in the older age groups, we're seeing an increase. And this is most dominant after 75 years vaccination. Okay, so some of the main takeaways. So the importance of figuring out this duration of boosting and waning of immunity on shingles outcomes. And as I said, recent studies have suggested less of an impact on shingles than originally expected. There's an overall reduction in shingles across time, so it's an additional benefit along with that additional risk of chickenpox vaccination. And we now have this platform where we can further, explore this relationship as we get more information, more data post-vaccination, which we are starting to get now. I mean, now it's been about 20 years since the chickenpox vaccine was implemented in Canada. Okay, so I'll now move on to the second kind of objective. And the objective of this study was to test the overall effectiveness of chickenpox vaccination, as well as the specific impact of two different vaccine schedules on chickenpox disease outcomes in Alberta over 75 years. And this is important not only because Canada, classic Canada, probably the States too, has a wide diversity of schedules being used. This graphic demonstrates that you can't see it all, but it does show that there were 8 different schedules used for chickenpox vaccine in Canada. And this is a combination of type of vaccine use, so whether it's varicella or MMRV, timing of the first dose, timing of the second dose, as well as, the other big factor in us doing this was that a lot of countries have yet to implement a chickenpox vaccine. So a lot of European countries don't have a chickenpox vaccine. So if they are thinking about implementing one in the future, to give some clarity about what schedule might be the most effective for them if they're kind of doing it from scratch. So we wanted to compare 2 of the most common schedules and specifically compare the timing of the second dose. So you see here in Alberta and Saskatchewan. In Alberta, this has now actually changed, partially because of this work, but they had a longer dosing interval between 12 months for the first dose and then 4 to 6 years for the second dose. So kind of at that preschool time. for Saskatchewan, they had a much shorter dosing interval. So it's what we call the short dosing interval, and there's about 6 months between the two. And you can see that these are two common schedules throughout the country. We further validated the model to empirical data for chickenpox, because that's what we were specifically looking at and was important to cost effectiveness analysis. So we looked at chickenpox hospitalizations and GP rates, made sure they were consistent. Because we were developing or building vaccine effectiveness and vaccine coverage into the model, we also had to make sure that the numbers we were finding in the model were consistent with what we saw in empirical data. So we did see maybe a slightly lower first dose vaccination rate, but still kind of within the range. And coverage rates were very consistent with what we saw in reality. Also, breakthrough rates were very consistent. So this is just an example of one run. And as you see here, I mean, it's kind of, kind of hard to see because the two different, they're slightly different, but the before vaccination rate was a lot higher, whereas following vaccination, we see a great reduction in the number of cases. And we see that maybe, and we'll dive more in depth in this, maybe Schedule 1, which is the shorter, the longer dosing interval, had slightly higher rates of infection. And to confirm that, we looked at the numbers and the confidence intervals around those numbers. So as you see here, the breakthrough rate, so the number of people getting chickenpox following vaccination, was quite a bit higher for the long dosing interval. So what they had been using in Alberta was quite a bit higher than for that shorter dosing interval, mainly because there was a lot of cases happening between that 12 months and 4 to 6 year between those two doses. Now this didn't, because breakthrough rates were quite small to begin with, it didn't translate to a huge difference in incidence. And like you see, these confidence intervals almost completely overlapped. So so less clear when you're looking at incidence that there was a major benefit of the short dosing interval. And I just want to make sure I leave questions for time, but I think I can, time for questions, but I think I can dive into the economic evaluation, kind of the third study. And in this one, we wanted to test the cost effectiveness overall of the chickenpox vaccine, because when it came out, a lot of the cost effectiveness studies that had been done in Canada happened before vaccination was implemented. There were still questions about how much the vaccine was going to cost, what the actual impact on incidence rates were going to be, what the impact on shingles was going to be. So there was a lot of unknowns. So we wanted to update that, as well as compare these two schedules and see if there was an impact on the schedules, or the schedules had an impact on chickenpox incidence. So we embedded economics directly into the model. So similar to what you see when you transitioned into the infected chickenpox state, you had a certain risk of seeing a physician or being hospitalized that was embedded into the model. We did a cost utility analysis. So the benefits were measured as quality adjusted life years. We both looked at it from a health payer perspective, as well as incorporating productivity loss, which we call the societal perspective, not a full societal perspective, but incorporates some of those societal costs. And so we captured costs, including physician visits, hospitalizations, prescriptions, out-of-pocket expenses, so things like over-the-counter meds, any prescription costs that aren't covered, productivity by age group, and then the cost of the vaccine itself and any adverse events associated with the vaccine. not a lot here. We also had a discounting of 1.5% and a time horizon of about 75 years. And I'll just jump into the results. So from the societal perspective, we saw that the vaccine was cost effective and was dominant. So it's cost savings, both schedules compared to no vaccination. And this, it didn't matter whether we were kind of incorporating that impact, so that increase we saw of shingles in the first few years or not. So either way, it was cost effective. And we saw that schedule, the short dosing interval might be slightly preferable to the long dosing interval, but when you taking uncertainty into account, I think it's less clear, and I'll show that. And then from a healthcare perspective, we saw that it was kind of less clear what the path forward was. So when we did take shingles into account, the cost per quality was quite high, higher than most thresholds that we would consider. With no shingles, though, if we didn't see an increase in shingles, then we can see it's quite beneficial. And maybe I'll just quickly talk about this. So this is the uncertainty. So this is costs. So a negative cost suggests that you're saving dollars. And then this is quality adjusted life years. So positive means that you are gaining quality adjusted life years. So all these ones, which are the dark blue and dark orange ones, represent the vaccine compared to baseline for no shingles. And we see that it is very cost effective. Cost savings, in fact, because you're saving dollars and you're getting qualities. When you do incorporate shingles, so this one, you see that there is some situations where you actually lose quality adjusted life years, and some where you gain. They are all having a reduction in cost, though. And then when you compare schedules, you see that it could go anywhere, right? Some are cost saving, some are not. Some long dosing interval is better, some short dosing interval is better. So this really suggests to me that, either strategy, either schedule is likely okay. If there's one that works better for feasibility purposes or implementation purposes, maybe that's what you determine it on. If instead you're starting something new and you have a choice, then maybe you go the short dosing interval, but not a lot in it. And I will leave it there to leave time for questions and any last minute thoughts from the group. Thank you.
Thank you very much, Ellen. There are multiple questions raised during the presentation, and I'm wondering if we can allow them to raise a question directly, Sharon, or?
Yes, I think they can type in the Q&A, and then we can invite them to speak as panelists.
Right.
Yeah.
So I already asked Sonju, Dr. Moon, to unmute and ask the question directly. There is a particular reason that actually Sonju have the pleasure or the honor to ask the questions, because Sonju, Dr. Moon is a postdoc under supervision of Tom Hurt and joint supervision of Michael Wolfson. So and Sonju raised a couple of questions. Maybe Dr. Moon, you can ask the question directly.
Yeah, he should be able to do so right now.
So I'm unmuted now? Okay.
Oh, you're fine.
All right. So I had two quick questions, but first is more a general. I was just wondering why. What are some of the ideas behind expecting the chickenpox vaccine to possibly increase the number of shingles cases for some age groups? Is this something that's that actually happened? And you showed us the data, but why would that happen?
So it has to do with this boosting effect. So how chickenpox works, or the varicella zoster virus works, is that you get chickenpox and then you clear the infection, but the virus actually stays within your nerves. And then at some point, you can get kind of a reactivation of the virus in your body. And this is true of a lot of herpes viruses. So it's a herpes virus. And you get a reactivation in your body, and that can cause shingles. So if you haven't had chickenpox, maybe if you get the vaccine, but if you haven't had chickenpox, you can't get shingles. You can only get shingles if you've had chickenpox. And one of the theory about why some people got shingles and some people didn't, even though everybody was getting chickenpox, is that there's a boosting effect. So I go around, maybe I have a kid and they get chickenpox, and so I am exposed to the varicella zoster virus, and this boosts my immunity. And so I'm like, okay, so now I don't have that reactivation, I don't get shingles. But if my kid is vaccinated and so never gets chickenpox, I never get that boosting effect, and therefore might be more likely to get shingles in the future. Does that make sense?
Okay, it's like variolation kind of idea.
Yeah.
Oh, thank you. And the second question that I had was about the modeling itself. Can you tell us a little more about the calibration process? You mentioned something about the 2.5 factor. I think I got confused a little bit at that point.
Yeah, no worries. I mean, it was complicated. So when we calibrated, all we had to calibrate to in terms of chickenpox infections was health admin data. So there was a study done by Dr. Kwong out of Ontario looking at chickenpox incidence based on health admin data. So based on people going to their physician and going to the ER with chickenpox and being diagnosed with chickenpox. But as we know, a lot of people don't do that. And so we found data in the population that suggested there's underreporting of chickenpox. If you're using health admin data, there's underreporting, and that underreporting factor is about 2.5 or 3. And when we applied this, then our model was able to match up with empirical data.
Oh, wow. Yeah. Okay. Thank you for this great talk. It was very interesting.
Great.
I'll unmute.
Thank you. So I don't know if other panelists have questions. You are automatically allowed to unmute and answer the question directly.
There is a question from Jumi. I just allowed her to come into panel session and ask her question.
You mean Dr. David?
Yeah.
Thank you. So I just want to ask if DOB means time from vaccination to boosting. I mean the gap between vaccination and boosting. Is that what you mean by DOB?
No, so DOB is the duration of boosting. So once I come in contact with a chickenpox case or potentially a shingles or breakthrough case, how much kind of extra time do I have until I might get shingles? So the kind of the impact of that boosting, how much extra protection does it give you? And is it a few years? Is it 2 years? Is it 7 years? What is that?
Oh, I see. Okay, thank you.
No problem.
Thank you, Jumi. Elena, I have a question. You mentioned during your presentation that Alberta's vaccination schedule was indicated it's based on your study. So this is for me as mother, this is very exciting that the agent-based simulation model is really well received. I wonder how the process goes. Is the Alberta government ask the Institute of Health Economics to conduct research and therefore is become input to the decision making, or is how this really the process really so successful. Alberta has traditional success, actually.
Yeah, I mean, it was kind of fortuitous, as these things often are. So I had published this work and had somebody I knew from my master's who was working in the ministry. And she actually works with the Alberta Advisory Committee on Immunization. And they were debating whether they wanted to shift for feasibility reasons. They wanted to shift from a second dose at 4 to 6 years to 18 months. It was just easier. They were thinking about shifting MMR. So they were thinking about shifting that one. And they wanted to know, oh, are we going to have to give varicella separately, or can we shift to give, MMRV, so along with chickenpox altogether? And but they were worried. They were worried about the if that would have any impact, if we would see increased cases at school entry, because that is why they had originally put it there. They wanted people to get vaccinated right before they were hanging out with a bunch of other children. And so they asked me to come present on my model because they knew it was out, and I had talked with them as I was kind of setting it up, letting them know I was doing this work. And so my model kind of confirmed that, based on our current knowledge, that there wouldn't be much of a risk of that shift. And if anything, there might be some of a benefit. So that's how it worked.
Thank you, Ellen. Congratulations, by the way. It's hard to have results have a almost immediate direct impact on policy and regulation.
It was very exciting.
Right. So time is running out, and Ali and Dr. Askari, anything you want to say on behalf of CIFA?
Sure. Thank you very much, Alan. This was a very informative and nice presentation. And I do have a question, but I will ask later, if I may.
Please.
Yeah. I just want to also thank everybody for attending today's session, and apologize for the video clip issue that we had earlier. It was just a piece of the first session that is already on the YouTube. We just want to play that again to remember Tom. For me, this was really a tragedy, because although it was a short period of time knowing Tom, it was for a year or so when we started this project together. I couldn't believe we were all shocked with this sad loss, and even so, this relationship was so short. I learned a lot from him. He was so always insightful, bringing lots of ideas, and also happy to work with everybody. A very nice colleague to work with. We really miss him, and it was, as I said, a shock to all of us, such a short and sudden loss. Thank you all again. I mean, we can play that, try it again at the very end. And I also, to finish, I want to mention that we will have two other sessions coming up. The next session would be with Dr. Melissa Tracy from, from University of Albany School of Public Health. And following that, on June, we will have Wade from our team to give another presentation on this line. I stop here, and Shireen can play the video to end, and with that, we will also conclude this session. Thank you all for joining us.
Let me thank Ellen again, and for the wonderful lectures, and we're looking forward to future more interactions with another network, the One Health Network.
And I'll be hosting this talk. So this is the first meeting of this subgroup focused on agent-based models. And if you see, Ali has posted a link for the lecture series. And as far as according to my count, we have scheduled 7 talks. You'll notice there's a 2-week interval between the talks. That's the pattern that we planned on. So today for the first talk, it's a pleasure to welcome Anna Bernstein.
Thank you, Sharon, for finally get us to hear the voice and this is opening the whole speak series. So with that, I want to again thank CIFA and the Mathful Network, Public Health Network to organize this big series. And again, want to thank Helen, Professor Rafferty for the wonderful lectures. See you next time.
Thank you.
You.
Thank you, Sharon.
Thank you.